Hello everyone in CardioMinds channel and welcome to the third type of heart failure we are going to speak about today, which is heart failure with preserved ejection fraction. As we mentioned in the last video, that heart failure is not a single pathological diagnosis but a clinical syndrome consisting of cardinal symptoms plus minus signs due to structural or functional abnormality or both of them, resulting in elevated intracardiac pressure and or inadequate cardiac output. Sometimes we call them backward failure and forward failure, and these abnormalities appear at rest and or during exercise. And remember this table describing the three basic types of heart failure, and as we mentioned, signs may not be present in the early stages of heart failure and in optimally treated patients, especially in heart failure with preserved ejection fraction, our main topic today. And as we find in this type of heart failure, which we sometimes abbreviate as HFpEF, the main criteria to diagnose are the presence of symptoms plus minus signs, LV ejection fraction more than or equal 50%, and objective evidence of structural and or functional abnormalities consistent with LV diastolic dysfunction and elevated LV filling pressures, including raised natriuretic peptides. And as we see in this table, this criterion is not essential to diagnose heart failure with reduced ejection fraction or mildly reduced ejection fraction. It is essential only for HFpEF due to the context of preserved ejection fraction raising suspicion of HFpEF or other pathologies mimicking heart failure. We should emphasize that the European Association of Cardiovascular Imaging defines systolic dysfunction as being less than 52 for males and less than 54 for females due to the difference in the cutoff point of ejection fraction between the two sexes. One of the questions that may come to our minds, why don't we call it diastolic heart failure as before? The reduced ejection fraction is considered to be systolic heart failure, but this name is not accurate because it does not exclude those patients with systolic dysfunction, or as we call reduced ejection fraction. That's why we usually omit this description and use heart failure with preserved ejection fraction. Another description that may come into our minds is heart failure with normal ejection fraction. The problem is that there is difficulty in interpreting the ejection fraction using different imaging modalities like echo, speckle tracking, and myocardial perfusion scan, and the main problem is the controversy regarding the precise cutoff point to define normal ejection fraction, which is varying with age, sex, and ethnicity. That's why we don't use this description, and we will stick to the description of heart failure with preserved ejection fraction. But before you put in your mind that the cutoff point to diagnose HFpEF is ejection fraction more than or equal 50%, which is of course an accurate information, the LV cutoff point to define normal will likely be higher than 50. We usually consider an ejection fraction between 50 to 55 as fair systolic function and may indicate risk of progression or deterioration of LV ejection fraction. However, the presence of a very high ejection fraction, for example, more than 65 or 70, should prompt a search for a pathology that caused shrinkage LV end diastolic volume, which is considered the denominator of ejection fraction, for example, in cardiac amyloidosis or hypertrophic cardiomyopathy. Kindly note as well that the patients with history of reduced ejection fraction less than or equal 40%, who later present with improved ejection fraction to be more than or equal 50% with the guideline recommended therapy, should be considered to have recovered heart failure with reduced ejection fraction, or sometimes we call them heart failure with improved LV ejection fraction. We don't call them heart failure with preserved ejection fraction because of course the pathology and etiology is completely different between the two subtypes. If we speak about the prevalence of this type, we should mention that over the past 3 decades, the prevalence of HFpEF relative to the total heart failure prevalence rose from 41 to 56%. 90%. This may be correlated due to the much more better diagnosis and detection of this type, which was usually neglected and not diagnosed before the time, and also due to the improvement in the imaging modality that can look for and detect the objective or functional evidence of HFpEF. And on the other hand, the incidence of heart failure with reduced ejection fraction fell from 44 to 31%, and the mildly reduced ejection fraction fell from 15 to 13%. So we are faced with increasing prevalence of HFpEF, which may be due to the more detection and much more common comorbidities resulting in it, and reduction in the incidence of reduced and mildly reduced ejection fraction, which may be correlated due to the improvement in the chances of myocardial revascularization. If we want to make a quick comparison between patients with HFpEF and the patients with reduced and mildly reduced ejection fraction regarding the natural history, the patients with HFpEF tends to be at older age rather than the patients with reduced and mildly reduced ejection fraction. Also, patients with HFpEF are more common to be females, while the other two subtypes are more often to be males. There is higher incidence of atrial fibrillation with HFpEF due to the increased left atrial pressure, left atrial volume, resulting in atrial remodeling in comparison to the other two subtypes. And also there is higher incidence of non-cardiovascular comorbidities like CKD beside obesity in comparison to the other two subtypes. We remember this table from the first video of the heart failure guidelines discussing the different causes of heart failure, how do they present, and what are the specific investigations needed to prove them. We detect from them what is relevant to us today. First of all, hypertension, as it is one of the important risk factors to develop HFpEF, beside other important, maybe uncommon, but of course are easy to be detected, like infiltrative causes like amyloidosis, sarcoidosis, storage disease like hemochromatosis, Fabry disease, and glycogen storage disease, beside endomyocardial disease, which may be caused by radiotherapy, endomyocardial fibrosis, or carcinoid syndrome. Let's move now to the most important part in our video today, which is how to diagnose HFpEF, which is considered a great challenge. We know from the literature that we have two famous scores to diagnose HFpEF. The first one of them is H2FPEF score, which have 6 dichotomized variables in order to calculate the score and the probability that this patient have HFpEF. We have body mass index more than 30, yielding 2 points, use of 2 or more antihypertensives yielding 1 point, presence of atrial fibrillation yielding 3 points, pulmonary hypertension defined as pulmonary artery systolic pressure more than 35 mm mercury, which we usually use the RVSP as a surrogate, and this yields 1 point, age more than 60 years yielding 1 point, and elevated LV filling pressures from E/E' ratio more than 9 yielding 1 point. So we have a score ranging from 0 to 9, and we can see that AF is the most important predictor of HFpEF in the logistic regression analysis of this score, and that's why we usually call HFpEF and AF as vicious twins. And at a score of 6 or more, in this case, there is a probability that this patient has HFpEF of more than or equal 90%. We use the H2FPEF score in euvolemic patients with unexplained exertional dyspnea in order to make a suggestion whether this patient has HFpEF or not. The other famous score which many of us have read about in the literature is the HFA-PEFF score. The first component of this score is P, standing for pre-test assessment, in which we assess the symptoms or signs of heart failure, comorbidities, risk factors, ECG, standard echo, natriuretic peptides, 6-minute walking test, or cardiopulmonary exercise test as an initial workup for any heart failure patient. Then we move to E, standing for echocardiography and natriuretic peptide, in which we perform a comprehensive echo plus measuring the levels of natriuretic peptides if not measured in step 1. In this table, we can see the abnormalities that we look for in echo, like the tissue Doppler imaging to measure the lateral and septal E' and then the tricuspid regurgitation velocity, plus the left atrial volume index and left ventricular mass index. And we can see here that according to the level and the degree of abnormality, we can calculate it as a major criterion giving 2 points or minor criterion giving 1 point. We also measure the level of NT-proBNP and the level of PNP in sinus rhythm or AF, and according to the cutoff point, we consider them as major criteria or minor criteria. If the score is 5 or more, in this case, we consider the patient to have HFpEF. Between 2 and 4, we need a diastolic stress test or invasive hemodynamic measurements. But if the score is less than or equal 1 point, it makes HFpEF unlikely. As we mentioned, if the score between 2 and 4, we move to the step of F1, standing for functional testing in case of uncertainty, like using diastolic stress test, example exercise stress echo, or invasive hemodynamic measurements to confirm the diagnosis. But if the score is 5 or more, we don't need this advanced workup. And finally, F2, standing for etiological workup to reach the final etiology, like cardiac MRI, cardiac or non-cardiac biopsies, scintigraphy, CT, PET scan, genetic test, or specific lab testing related to the provisional diagnosis. So finally, we can have this diagram illustrating the main steps of the HFA-PEFF score. But please remember that you need to exclude in your clinical assessment other conditions that may mimic the HFpEF and make you confused, and that's why we need these scores like lung disease, anemia, obesity, and deconditioning. There is a famous article published in 2021 related to the generalizability of these two famous scores to diagnose HFpEF, and they mentioned that although these scores were associated with measures of severity and biomarkers related to HFpEF, they demonstrated just a modest and differential ability to identify HFpEF non-invasively, and so needing additional functional testing to confirm the diagnosis. So in many cases, these scores are not enough to diagnose HFpEF. That's why in the 2021 ESC Guidelines, they put some diagnostic markers helping you to diagnose and confirm HFpEF. For example, the LV mass index and relative wall thickness, as the presence of concentric LVH is supportive, but its absence does not exclude HFpEF, and they put the cutoff point to consider them abnormal. Then the left atrial volume index, which is related to the body surface area, that's why we call it index. And in the absence of AF or valve disease, left atrial enlargement reflects chronically elevated LV filling pressure, and the cutoff point, as we see here, is different between sinus rhythm and AF. And using tissue Doppler imaging, we can measure the E over E prime ratio at rest, which has a sensitivity of 78 and a specificity of 59% for the presence of HFpEF by invasive exercise testing. And if we use a higher cutoff point of 13, it has lower sensitivity but higher specificity. Then we use the biomarkers, which we use them in the last score, which are the BNP and NT-proBNP in sinus rhythm or AF with different cutoff points. But remember that up to 20% of patients with invasively proven HFpEF diagnosis have natriuretic peptide below the diagnostic thresholds, particularly in the presence of obesity. So normal level of biomarkers does not exclude HFpEF diagnosis. And finally, the pulmonary artery systolic pressure, more than 35 mm mercury, which we use it in the first score, besides the TR jet velocity at rest or during exercise, which has a higher specificity for the presence of HFpEF by invasive exercise testing. After these criteria, if you are still in doubt of your diagnosis, you can use the cardiopulmonary exercise testing to confirm a reduction in exercise capacity and differentiate the causes of dyspnea. Exercise stress testing, looking for ECG changes besides the metabolic equivalents. Diastolic stress echo, as we mentioned before, to measure the E over E prime ratio and the TR jet velocity with stress. Invasive hemodynamic testing to measure pulmonary capillary wedge pressure at rest or with exercise, and LV and diastolic pressure with these cutoff points to consider them abnormal. But we need to remind ourselves that in the absence of any disease-modifying treatments for HFpEF, as it was proved for the reduced ejection fraction subtype, the current guidelines don't necessitate gold standard testing in every patient to confirm the diagnosis of HFpEF. However, the greater the number of objective non-invasive markers you find in your patient of raised LV filling pressure, the higher the probability of HFpEF diagnosis. After we made our diagnosis, we want to treat our patient. How can we treat HFpEF in the absence of disease-modifying treatments? We remember from the last video the heart failure with mildly reduced ejection fraction. We mentioned that most of the guideline recommended medications are just class 2B due to weak evidence, and the only class 1 was the diuretics for symptomatic treatment to reduce hospitalization, improve symptoms and signs. The dilemma in HFpEF is that there is no treatment shown to reduce morbidity and mortality so far, and so there are no clear recommendations for a specific medications for HFpEF except for diuretics including loop and thiazides to a lesser extent. None of the large randomized controlled trials conducted in HFpEF achieved their primary endpoints, including the PEP-CHF trial for perindopril, sham preserved for Candesartan, I-preserve for Irbesartan, TOPCAT for Spironolactone, DIG preserved trial for digoxin, and PARAGON heart failure for sacubitril valsartan. The seniors trial showed that nebivolol significantly reduced the combined primary endpoint of all-cause mortality or cardiovascular hospitalization, but it included only 15% with ejection fraction more than 50. That's why we cannot extrapolate its results. However, the vast majority of HFpEF patients have underlying hypertension and or coronary artery disease, and so many are treated with ACE, ARBs, beta blockers, or MRA. In the PARAGON heart failure study at the baseline, more than 86% of patients were on ACE or ARB, 80% were on beta blockers, and more than 24% were on MRA. And so the FDA endorsed the use of ARNI and Spironolactone in those with ejection fraction less than normal, including those with mildly reduced or preserved ejection fraction. The ARNI, as we saw in the subgroup analysis from the PARAGON heart failure study, showed a reduction in hospitalization with ejection fraction less than 57%, and the meta-analysis of the PARADIGM heart failure and PARAGON heart failure studies showed a reduction in cardiovascular death and hospitalization in those with ejection fraction below the normal range. That's why ARNI can be beneficial in heart failure with preserved ejection fraction, and of course it has a symptomatic improvement besides some data regarding mortality benefit but not proven as a recommendation so far. Regarding spironolactone, in a subgroup of individuals in the TOPCAT study recruited in the Americas, it showed significant reduction in the primary endpoint of cardiovascular death and hospitalization, and in a subsequent post-hoc analysis, it showed significant reduction in outcomes for those with ejection fraction less than 55%. As of course we know that spironolactone is considered to be a potassium-sparing diuretic, so it exerts symptomatic improvement besides protecting the patient against hypokalemia. As we see that these trials were not reflected on clear recommendations regarding specific medications to start in HFpEF patients. So the only recommendations that we are going to see in HFpEF is class 1 to screen for and treat etiologies, cardiovascular and non-cardiovascular comorbidities, and a class 1 for diuretics in congested patients to improve symptoms and signs, nearly the same as the treatment of heart failure with mildly reduced ejection fraction regarding diuretics, but we don't have class 2B for other medications in HFpEF. So we can summarize the lines of treatment of HFpEF as treat the underlying etiology, risk factors, and comorbidities as they are helping in controlling the patient's symptoms and signs, reduce body weight in obese patients because it is contributing to the pathology, improve exercise capacity by supervised exercise program. Loop diuretics are preferred in congested patients, sometimes we use thiazide for hypertension, but loop diuretics are the main type that we can use. And so far, there are no recommendations to prevent you from starting ACE, ARB, ARNI, beta blockers, MRA, or SGLT2 inhibitors for HFpEF patients. So you can start them according to the underlying etiology and comorbidities, but there are no recommendations to favor their use in HFpEF. And so at the end of our difficult video today, because I know it may be confusing for some of you, but we tried as much as we can to put the facts related to the diagnosis and treatment of this difficult type of heart failure. HFpEF is an easily missed diagnosis if it wasn't put in your mind, particularly if you consider that ejection fraction more than 50 is an exclusion of heart failure diagnosis, which is wrong. Put in your mind to search for objective evidence in echo related to elevated LV filling pressure, as we mentioned before. Search for underlying etiologies and comorbidities that may result in HFpEF, and of course start appropriate treatment, primarily diuretics, beside blood pressure and rate control. And you can use the prescribed heart failure medications for reduced ejection fraction in this type, but you should know that there are no strong recommendations to favor them and no recommendations to prevent them. Thank you very much for watching this video, and wait next week for another interesting video in the heart failure guidelines.